Welcome to Transforming Relationships. We have just finished a really thought-provoking interview with Dr. David Patterson that you're about to hear. We just want to bring your attention to a couple of things. First off, this is a wide-ranging interview. We spend the first hour talking about Dr. Patterson's research, his clinical tips about working with pain, some anecdotes. And at about the hour mark, we shift to a really different kind of pain where David talks about the grief of losing his son, Billy. And we spend about 15 minutes just talking about what that was like for him and just talking about grieving the kinds of pain that is really hard to even put into words. So David Alter, anything you'd like to add to kind of let our audience know about this upcoming interview?
Well, thank you. All I want to say is this. Chronic pain is a tremendously common experience. And as a clinician, I've worked many, many years with people in chronic physical pain. But I have to say that no one I've ever met with physical pain isn't also experiencing significant emotional suffering. And so in this conversation, I think you'll hear with sensitivity how Dr. Patterson addresses the physical, the personal, the emotional aspects of chronic pain and leaves us with a sense of hope about what can be done. Some really practical, proven methods for being able to heal. I hope you enjoy the episode.
Welcome to Transforming Relationships. Eric Spiegel and David Alter here with you again. And this week we've got a great guest, Dr. David Patterson. And David is here to talk to us about how we transform our relationship with pain. And David is an emeritus professor of psychology in the departments of rehabilitation, medicine, surgery, and psychology at the University of Washington School of Medicine. He has not 100, not 150, but 200 empirically peer-reviewed publications. No small feat there. And he also has a recent book published in 2024 with Elena Mendoza called Clinical Hypnosis for Pain Control. It's a great book. I highly recommend you get it. It's great because what it does is it doesn't just present the literature on pain treatment with hypnosis, and it does a great job of that. But it also really gives clinicians some very varied ways of using hypnosis with pain control. And that's actually going to be one of the topics we're going to ask you about today, David, is the many different ways that you have approached treating pain in psychotherapy, including through hypnosis, immersive virtual reality, meditation, Zen Buddhism. So we're excited to talk to you about all of that. Welcome to the show, David.
Thank you. It's nice to be here.
Well, to get us started, one thing I'd love to ask you more about is we were exchanging some emails getting ready for the show. And somewhere in the course of the correspondence, the word hypnotherapy came up. And you're laughing because you sure had a reaction to that. And I got to tell you, I mean, I got it. I agree with you, but help our audience understand that reaction. Maybe you could just tell them what you told us, and that could be a great jumping off point.
Yeah. Well, it's very kind of you to bring that up. And I'm tempering my attitude towards that a bit. As you mentioned, there's hypnosis, of course, which has been around for 300 years or whatever. And very often writers will use the term hypnotherapy, used it in the title of some of my articles. And so, before I realized it, and what I've concluded is it's really hard to define what hypnotherapy is. I mean, there's hypnosis and there's various things you can do with it, like you can regress a person to periods earlier in their life to access those resources, and there's various phenomena, but there isn't really a set of empirically supported tenets to hypnotherapy, and it really isn't defined when a clinician or a writer are using the term hypnotherapy. It's like, what? Can you really say what it is? And when in psychology, when we've really been pushed to have empirical evidence for what our therapies are, I think that presents a problem. Now, I will say that one of the best books was ever been written was by Erica Fromm and Dan Brown, and and basically what I think they were doing was using hypnosis combined with things like psychoanalysis and attachment theory. And Erica, for example, I know you very often use hypnosis with attachment disorders, and I'm sure both of you two do. What I prefer to see hypnosis combined with psychotherapy. And we know from Irving Kirsch's work in 1995 that hypnosis can greatly enhance psychotherapy. So anyway, the editor of our journal is a good friend, Gary Elkins, and he seems to be telling his students to use the term hypnotherapy. So I think I might be in a losing battle with my friend Gary, but that's kind of a summation of that topic.
Well, what you seem to have touched on is an important part of what I think our discussion will encompass. And that is, when is what we're trying to do to help people in pain reducible to a technique, an empirical, reproducible, almost manualized set of techniques, versus at the other end of the continuum is a relational based process that uses certain strategies and interaction patterns and so forth. And it's sort of a false distinction because it's probably a both, but at least that's the reaction that I'm having about, well, is it hypnotherapy or therapy with hypnosis, and what is hypnosis, and blah, blah, blah. So any reactions, Dave, to that continuum?
Yes, and you're actually giving me the opportunity to start out of the gate with, I think, a critical concept of using hypnosis with pain, and for that matter, any medical or psychological approach. And that distinction is the difference between acute and chronic pain. And if you don't mind, I'll just take a minute to define the difference between these. Acute pain is that pain that comes with tissue damage. It can be like when someone has been traumatized and has lost an arm. It also comes with medical procedures, childbirth, burn care, dentistry. But the nature of acute pain is it's very intense and it's short-lived. Okay. And, very often we're talking a matter of minutes or hours. And another aspect of acute pain is very often predictable. Well, acute pain responds extremely well to medical interventions. It's actually amazing what it can do with selective guided epidurals, and you can numb certain parts of the body. And then also the new generations of opioids that are used in the hospital are really pretty remarkable. So both medically and with psychological approaches, it's much easier to control. And I would say that's the case with hypnosis too. Hypnosis is very effective for acute pain. And if you look at the history of hypnosis, going back to James Isdale's work, there's Braid and Isdale, they're surgeons that did hundreds of surgeries with hypnosis as a sole anesthetic. And it's very interesting that it was really the advent of ether before we had ether, hypnosis was one of the only ways to work with this difficult type of pain. And I would say that to this day, that controlling acute pain is one of the best applications of clinical hypnosis. With the hypnosis, you can go and very often greatly diminish the pain and take it away. So that's one side of the coin, and we can talk more about what it looks like to use hypnosis with this short-acting, very intense pain. Now, the other side of the coin is chronic pain. And chronic pain, by definition, lasts 3 to 6 months. Also, almost by definition, with chronic pain, there is no longer sensory input. So what happens is someone gets injured, they hurt their back, and at first there's a very viable neurophysiological explanation for the pain. But after time, the pain exists without what we would call the nociception or the incoming signals. So chronic pain not only does not have a physical cause, but it has a horrible response to medical interventions. So, for example, back surgery, 30% of people roughly get better with back pain surgery, 30% get worse, and 30% stay the same. And it is a real challenge to control chronic pain. And so that's why we very often say it's better to manage chronic pain. Going back to some of what you've been talking about, change your relationship with chronic pain rather than to try to control it. So that I'll just throw that out as kind of a really useful distinction when we are talking about relationship to pain and how we might use hypnosis.
David Alter, could I ask a follow-up question? I didn't know if you had one raring to go.
Okay. Yeah, go ahead.
I am curious. I'm going to have to I'm going to have to refer to you as DP, David Patterson, and you as DA, David Alter. All this David stuff is going to get me really confused here. DP.
You can just call me King.
King, okay. King Pat here. I was wondering, you said that, look, the standard medical procedures don't work with chronic pain. And I think what you were speaking to was that because what has happened is that there are other brain pathways that have now taken precedence, the affective pathways, the associational pathways, the belief systems about the pain. I was wondering whether you could explain to our audience why in those kinds of situations hypnosis might be a better choice for treating chronic pain than some of the standard kind of medical interventions that people are used to associating with pain reduction.
And I really appreciate the question, which I'll address, but I should step back and say very often medical interventions are great with chronic pain, particularly surgery. I remember my 90-year-old mother there's a great neurosurgeon here, John Lozier, who did a lot of the original work. He actually operated on my mom and she had a good outcome. So, and there's also new medications that are being developed. So medicine is often very useful, but the efficacy drops way down. And as a way of circling back to your question, I want to explain a bit more why chronic pain is so refractory to both medical and psychological treatments. And the reason for that is a phenomenon called neuroplasticity. So we now know that if humans experience pain long enough, there actually is no pain center in the brain. There's 5 areas of the brain that register pain. And we know that if people have had chronic pain over long periods of time, their brain begins to respond as if they're in pain long after the nociceptive stimulus is gone. So these areas of the brain just become well developed and hypersensitive to pain, and then ultimately all it takes is environmental stimuli, and the brain in a person's brain is saying you're in pain. Okay, now that's one of the main explanations for why you get this pain persisting for months or years after the disease has gone away, after the injury has healed. So to circle back to your question, why might hypnosis be, I wouldn't say it's more useful than medical approaches, but I think it has a great deal of potential. And I think there is potential for hypnosis to reverse neuroplastic processes. And David Alter, I imagine that you've written about this at some point in your works, but I do think that it's one of the promises, and it's hard work because, again, these things become ingrained, but hypnosis can be a really effective way. One of the biggest things we know about hypnosis is it can change human perception, and one of those perception is pain. Now, I will say it doesn't change the pain perception long. You have to combine hypnosis with a lot of different approaches to make it last. But I guess the shortest way to answer your question, Eric, is that I think there's potential for hypnosis to reverse these imprinting and neuroplastic processes.
Thank you.
So picking up on that, Eric, this is DA talking. The idea of neuroplasticity to me is really important here because you can have conservative neuroplasticity, which means it's changing the neurophysiology, the neural networks of the brain and body are changing so that they help maintain something. And then there's creative neuroplasticity, where we're using that same capacity to shift to produce something new, right? To not stay stuck in what was. And what I heard you say, Dave, is that for reasons that we don't fully understand, after the body has healed, but the brain has the capacity to remember and experience and to encode it in different areas throughout the brain and body. It has the capacity to remember, oh, if I get this stimulus, then I'm going to activate that remembered experience that we call chronic pain. So it seems as if part of what you're doing, combining the plasticity inducing capacity of hypnosis, so it introduces a certain fluidity into those neural networks, so that momentarily, in a sense, the brain and the body are saying, well, okay, we could go this way, we could go that way, we could go this way, could go that way. Which way might be more helpful? And that's part of what you're instilling. And then when you combine it with other things, you're now moving toward conservative neuroplasticity. You're inducing a change that persists in a healthy direction. Is that a fair summary, would you say?
Yeah, I think that's very well put, and I would expand that to you both are much more involved in psychotherapy, but I think that's also the goal of psychotherapy, is that people just get stuck in these patterns of doing things, and it's really difficult to get them out. And I think probably all three of us have found that hypnosis very often can, to put it in more colloquial terms, unstuck people or unstick people and get them to try these new things, which, I think could also be called as the way you were using neuroplasticity, David A. So, yeah.
So in your experience, Dave, going back to the continuum we talked about in terms of empirically reproducible evidence-based approaches and the relational dimension, in your work with your many, many, many patients who have suffered from chronic pain, how central have you found your relationship to the patient to be in evoking or eliciting the kind of positive potential that you're aiming for?
Well, it's essential. So how important do I find my relationship in creating some of these shifts? And once again, I'll go back to the acute chronic distinction, because the relationships are essential in both approaches, but they're quite different. Now, people in acute pain, you think of someone that goes in a ER and they've got this, blood splurting out of a wound, or people are in the dentist and the drill's coming at, or the Novocaine is coming at them. Just that in itself. And very often people in acute pain situations are frightened. And I also think hospital situation, there is what I would call an adaptive form of dependency. So if you're in a hospital, you have to become dependent on the staff, and you have to trust the staff. And, it's very interesting in psychotherapy. One of the rules is you never touch a patient, and there's good reason for that. Now, in a hospital, on the other hand, it's that we're asking people to take poops in bedpans. And not only is touch appropriate in the hospital, it's like when a lot of my early work was in trauma care, a lot of what I would do in the ICU is go sit down next to the patient and hold their hand. Okay. And when I trained interns and residents, I said, this isn't your psychotherapy scenario. This is quite different. But going back to the relationship issues with acute pain, it's very important for the healthcare worker, whether it's a psychologist, a nurse, a doc, whatever, to show a lot of confidence and to basically say, not in these words, but I'm controlling the situation. I'm controlling the world, the room. I am going to make you feel better. And that confidence has to be instilled in the patient. And along with that, what you're often doing is you're telling the patient what to do. And I like to use an example of a couple of years ago. I was with a patient who he's like 6'6", and he had a craniotomy from a head injury, and his there was still this open area in his skull. And I was in a therapy session and he started having a seizure, and he got really scared, and he decided he was going to go. Well, he didn't know where he was, and he could barely walk. And so I somehow alerted the nurses, and the nurse brought in a blood pressure machine. And as soon as he saw the blood pressure machine, he really freaked out. And then he decided he was going to leave. So the nurse says, "What should I do?" And I said, "Call a code," which we have a code for all able bodies to come, subdue a out of control patient. So here I am, I'm 5'8", and I'm hanging on to this like 6'6" guy like a chihuahua, trying to slow him down, and I don't, when he had the seizure, I immediately ran behind him and grabbed his head and protected his head, which you do. But then he starts walking out. And so the code team couldn't find us. We were tucked way back in a hallway, and they finally all came running around a corner, and they said, "What's going on, doctor?" I say, "Mr. Jones here has just had a seizure, and he's quite frightened." And one of the security guards had a wheelchair, and he said, "Mr. Jones, please have a seat here." And the patient did, and they brought him down to the ER, and everything was great. But that wording, "have a seat," that's very often what we're doing to interacting with someone in crisis and acute pain. It goes back to even an old-fashioned transactional analysis. You become a parent to a child, right? So the relationship with someone in crisis is quite different, and you're being very directive, and that's what comes across in the relationship. And I could talk about chronic pain, but I didn't know if either of you wanted to comment on that part of it.
Well,
Go ahead, Eric.
I'll just share some really random associations, which is the kind of stuff I love to throw into hypnosis. So first thing, when you were talking about your patient, Mr. Jones, I was thinking about the Counting Crows song, "Mr. Jones and me," and just sha la 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 la, and seeing you as like a little chihuahua trying to hold on to Mr. Jones's shoulders and prevent him from having a seizure. Besides the fact that chihuahuas can be soft and cuddly, it's amazing, isn't it, how we have to just kind of bring in all of our senses in the moment to find a way to be with a patient in a variety of situations. And that's a really kind of unique kind of situation, but he had to know that you were there. He had to know that you were there to kind of settle him down.
Mm-hmm. Yes. And I like that, Aaron. One of the things the ways we would put it is to model calmness to the staff too. Because if you get someone in that mix who's really unplussed and so on, the patient feels it just like a child feels a scared parent. So
picking up on that, my association, as you said, Dave, that Eric and I spend more of our time in the psychotherapy world. But I've done a fair amount of work in the chronic pain field. I used to consult for a few years at a pain hospital here in Minnesota. And what I found is I always had to bring in the way that we've learned that words have multiple meanings, right? Mm-hmm. That I have to talk to the patient in chronic pain at multiple levels. And what I mean by that is I have to be able to touch you, but not physically, right? But you have to feel touched by our connection. I'm going to touch the places that hurt, but in a way that helps them to feel better. Right? That you're going to allow yourself to be touched in the places that hurt so you can discover a way to perceive it differently. So there's this whole way of interpersonal connecting to their psychology, to their physiology, to their interpersonal space, so that, as you were alluding to, Dave, there's a great sense of trust that is happening. When I think developmentally, the first sense that human beings experience is the sense of touch. We're held in a parent's arms, and if it's a good enough parent, we feel safe, we feel held, we feel secure. And in some ways, whether they're 2 days or 90 years old, there's still that sense that this person who's trying to help me has to quote unquote touch me, and I have to allow myself to be touched so that we can produce a change. That's been my experience in working with chronic pain patients, right? And the more we can create a way to be touched safely, the more suggestible and the more responsive to the interventions they are. That's what I have found.
And I think, so I had mentioned what the relationship is when with a real acute pain situation, and so the next question is, what's the relationship with chronic pain? And in David A, I think you said something really critical. First of all, it's quite different. One thing that is quite common with people with chronic pain is many of them have had their pain dismissed over and over again, and they feel dismissed as people, they feel dismissed as patients, and the classic line is that many of them come back and report that, well, the doctor told me it's all in my head. Okay. And they feel completely invalidated. And I think some of those ways that you were just talking about, David A, to engender trust are very important. Now, I'll take that a bit further with basically what my model is, and Elena, who I've written, and Mark Jensen, that the way we're often helping a patient manage chronic pain is I'll take a step back. Musculoskeletal pain, like back pain and joint pain, the primary treatment and management for joint pain and back pain is to increase activity. Okay, period. And now you take a hypnotist that says, I'm going to take your pain away, or I'm going to help you manage your pain. Well, they're missing the boat when, for most of the patients, the main goal should be increasing activity. Okay. Now, so when we're talking in relationally, I think it's Twain that said, Twain had a saying along the lines of, to be healthy is to eat what I don't want to eat, drink what I don't want to drink, and do what I don't want to do. Okay. And I have to say that there's a big element of that, of working with chronic pain. We want to get people out exercising. We'll talk about meditation at one phase. We're really trying to get them to change their lifestyle. Now, I will contend that just like in any type of psychotherapy, if you tell people what to do too much, there's just something about us people that we push back. So I think a lot of the relational stuff with chronic pain is to get people to try new approaches and do all these things that we know will reduce their suffering. And that's a whole different approach than what I just described with acute pain, where you're being very direct and even parental at times. With the patient in chronic pain, it's like coaxing a deer out of the woods as far as trying new approaches.
And David P., what you just said touched on something that is, I think, a big part of my work, right? Which is decoupling the experience of pain from the possibility of activity. I think a lot of people, I'm in pain, so it's too dangerous to be active. So, I often say something in the process of hypnosis like that, I don't know whether you're going to feel the regular amount of pain or no pain at all, or somewhere in between. Maybe you're going to feel a lot of pain, but not as much pain as you've been feeling. Maybe you're going to really feel a noticeable reduction in pain. It's not going to be that much. But what I do know is that you're just going to pay less and less attention to whether you're in pain as you find that you're doing more and more of what you love to do. So that sooner or later, I don't know just when, it's just going to be easy for you to just be engaged in the things you enjoy doing without really paying attention to whether you're in pain or not, or how much or how little there is. I think that is a nice way of separating that. I wonder if you could say more about, how you encourage patients to decouple those two things.
Yeah, well, you did it. I mean, you just gave a really nice example yourself, but a couple of, just even the example you gave in the way you're talking to patients, a couple of things I want to say is first of all, there's multidisciplinary pain programs. They were much bigger 20 years ago, but you have a patient come into a clinic and you got this team of docs and nurses, psychologists, physical therapists, and they looked at the effect that this had on patients, and they saved the U.S. economy billions of dollars in unneeded doctor's visits, and they get people back to work, and all these satisfaction with life increases But what doesn't change on average when Dennis Turk did a meta-analysis of all these programs is their pain doesn't change, right? And it's fascinating to me. And so you're saying decoupling, but very often the goal is to get people moving. And the other thing is, one of the best things, anyone with really horrible chronic pain will usually tell you that the only way they really get by it is by distracting themselves. And that's why people with chronic pain very often feel it the worst at night, because there's no distraction. During the day, they're able to get involved in daily activities. And that's I think some of the decoupling that you're talking about, but it's really interesting that the longer I study this and work with this, the less I see pain reduction being the goal. It's really engaging in these other resources and moving away from pain, and rather than focusing on it. I mentioned just one interesting example. Bill Fordyce was all of our mentor. He was a old-fashioned operant psychologist, and he was the one that really started making pain be, let's study pain as a problem rather than pain as a symptom of something else. But he has a videotape. We had the first pain hospital ward where people were admitted just to take care of pain, and there's a video of this guy with horrible pain, and he could only walk like in this type of shuffle, and it would take forever to get him around the ward. And they put him on a behavioral program, and they fast forward this, and 2 weeks later, he was speed walking around the ward and knocking over carts and bumping over nurses. It was really funny. And what they did is they, built up this alternative response. It's a hilarious video. Yeah.
Well, I like what you're saying. I think it fits with my actual experience. For me, when I work with folks with pain, I tend to focus a lot on the meaning that they attribute to it. And what I mean by the meaning is the meaning about the quality and value of their life. Many of the people that I see develop this sort of existential view of their life as so diminished, so limited, so much loss from the kind of life they could have or should have been able to live. And so any time they have the sensation, it just reinforces the sense of the hopelessness of their life. So a lot of what I have tried to do, and I'm wondering what your reaction to this is, Dave, is that if I can combine a repurposing of the meaning of life and increased activity, then the relative importance of the sensation, the nociceptive sensation, is further down the hierarchy. If you ask them, well, how is it right now? Well, yeah, thanks for asking. Thanks for reminding me. It's still there. But 5 minutes ago, they were engaged in their life, in a purposeful life at a much higher level. So I'm curious about sort of existential meaning, activity, and nociception.
So it's a great point, but there's so many levels to which I can respond to this. And I want to start more on a simpler one, because you're talking more existential reinterpretations, but that probably the main logical treatment for chronic pain is CBT. Okay, and I think Dennis Turk and his father-in-law Meichenbaum had a lot to do with this, but we found that patients with chronic pain have these very dysfunctional thoughts. And Mick Sullivan is a Canadian psychologist that's done wonderful work with this. They have very dysfunctional thoughts, and changing the thoughts to more adaptive ones, and you references David Abe, can be helpful. But I want to tell you about a study that I did with Mark Jensen and our team. And I was a therapist on this study, and we had 3 groups. One group got hypnosis to alleviate their pain. One group got cognitive interventions. We, bring them through the thought records where they learn to reinterpret their thoughts. And the third was like educational control. And education is an intervention by itself, it turns out. But all 3 approaches reduce pain. Cognitive restructuring had more impact than hypnosis. But then there was a group that got both cognitive interventions and hypnosis combined, and they did the best. Okay. And it kind of goes back to one of our very first points about combining hypnosis with psychotherapy, is that if you can identify some of the, in your case, David, you're talking about this really existential futility, and build resources with hypnosis. We will be talking about this. We do a lot of it with motivational interviewing, but anytime you can get onto these concepts, and we know, again, going back to Kirsch's meta-analysis in 1995, that hypnosis really increases the effects. There's one other association to that, what you brought up, David, was, and that's the use of ACT, acceptance and commitment therapy. One of the things I think that therapy has figured out well is, well, as you know, it's a lot of values, that when patients' goals differ with their values and there's a discrepancy, there's a problem. But putting it in terms of managing chronic pain, if someone still wants to run marathons, and if they do, it's going to pretty much lead to a knee replacement. One of the big things is dealing with the grief over what they're losing. Like when typical marathoners, when they can't run them anymore, they start grieving. So you very often have to work with that grief, but you also have to get them to set the bar in life differently. Maybe satisfaction isn't going to require jumping over a 5-foot bar. And if you can put that bar lower, then your satisfaction will accordingly change. And so that association came up when you were talking, Alter, about that. Yeah.
Yeah. Exactly. Do you have, from a research perspective, it's a touchy question, do you see any extra psychological burden that the patients who tend not to respond that well carry? In other words, if I go into a program with chronic pain, because of my chronic pain, and unfortunately I don't have a great outcome, if I have come into that program with a significant history of major depression, or I've come in with an on-again, off-again struggle with addiction, or if I've come in with a program of traumatic abuse history. In general, does that extra psychological history weigh heavily on my capacity to achieve a good outcome, or not so much?
Oh, it absolutely does. And Elena Mendoza and I have come up with it. It's in the book, but it's also in an article in International Journal, 8 modules of psychotherapy for managing chronic pain. And one of the modules is, as you said, psychological, David, and that's 30% of people with chronic pain have major depression. And very often treating the depression helps with the pain. But there's something that you said that I think is really critical to this, and it makes for the hardest people to get to are what we in the field we talk about people who have illness conviction. So they're experiencing this pain, and they say, I need surgery, and it's the only thing that will make me better. And when I first started at our trauma center at Harborview, there's a woman that said, you need to cut off my foot. That's the only way the pain's going to go away. And she was quite convincing, and even getting the doctors to buy in. And she didn't realize, of course, that the way we're wired, even if it cut off their pain, she'd still be having a phantom sensation in that same place. There is a certain proportion of people that have this illness conviction where it has to be a medical procedure or a medication, and that's the only way that they're going to feel better. There is some of that goes on with opioid analgesics. That's kind of another class. But this is where I think the real art of the relationship comes in with managing chronic pain. And the first module that Elena and I talk about is motivational interviewing. So we ask the patient what their model of their pain is. Why do you think you had this pain, and what do you think it's going to take to get better? Now, if the patient says, you have to chop off my foot, that's the only thing that's going to work, they're going to respond quite differently to hypnosis and a lot of other techniques than the patient that says, well, I have some deteriorating joints, but if I do yoga and stretch, I'm able to manage the pain fairly well. And in the process of motivational interviewing, in a very gentle dialogue, we try to get patients to shift out of the somatoform model or that something has to be fixed and into a model where they're willing to consider some of the things that we can do with hypnosis or any other types of psychological approaches. But very often patients can get stuck in that, and it's very similar to working with someone who has even a functional disorder. I mean, we have people that behave as if they have a complete spinal cord injury and there's no damage. But the way you work with people with functional disorders like that is you buy into their model from the start. And so we send them to physical therapists just like we would send a patient that actually does have the spinal cord injury, and they do quite well. But you don't really challenge their belief system and say, no, you're nuts. There's no evidence of a spinal cord injury here, which really only serves to irritate the patient. So I'll stop there for the time being.
Let me ask a couple follow-up questions. First thing, could you define for our audiences what a functional disorder is and how it is different than a traditional kind of chronic pain presentation? I think you've started to do that in the answer you just gave, but I wonder if you could just clarify on that a bit more. And my second, okay, go ahead with that. Yeah,
I'll do that one. And I appreciate that, Eric, because functional disorders, that's jargon, and it's hard to understand, and it's hard to grasp even for many neurologists. Okay. Mm-hmm. But I'll just say a functional disorder is when a patient is responding as if they're ill or injured, and the medical factor is not there. Okay. I just heard from this friend today, but there's a kid that was growing up next door to me, and his family, when he was in middle school, his family was giving his older brother more attention. And at one point he developed hip pain, and his mother was all over it and just really concerned about him and put him in an ambulance. And the next thing you know, he shows up to middle school in a wheelchair, and he was just loving the attention. And my other neighbors were orthopedic surgeons, and they said, Dave, they need you more than they need us. And so it was just an example of learning factors. There could be all kinds of stress, all kinds of learning factors that where they show up as if it's a real illness, but the illness isn't really there. It's kind of a hopefully simpler way to define what a functional disorder is. And I can get to what the rest of your question, your next question, Eric.
Well, I've got a couple on cue here. So DA here, David Alter, I'm going to try to pace myself with you.
So do you want to go, or are you?
I got like probably 2 or 3 questions lined up, ready to roll, but I can kind of pace myself with you depending on where you're at.
I'll make a quick observation that you guys may frankly not agree with. I know years ago now, a guy named Bruce Lipton wrote a book, The Biology of Belief, that whatever else I took away from the book, it sort of muddied the waters for me about what's physical and what's not, right? What is existing in some other way. I'm thinking about it in relation to my internship year. So I'm not even done with graduate school yet, but I was working in a rehab hospital, and my mentor was telling me that he had been called to do a consult with a patient with diabetes who was going to have his leg amputated, right? And he was called in to go consult with the fellow because the surgical team was saying, I think he's really depressed, and patients with depression, when we amputate, they don't have very good outcomes. So a week or 2 later, I see my mentor and I said, hey, how did that guy do? How did he recover from the surgery? And he said, we didn't do the surgery. I said, really? Did he pass away? He said, no, we didn't need the surgery. I asked why. What happened? So the psychologist, the behavioral medicine specialist, sat with him and realized that he had essentially already amputated the limb in his belief system. Nothing can be done. It's gone. What he had never done is grieve it. So he sat for that hour in a relational space talking to this fellow, and over the next week, the leg began to pink up. He began to revascularize somehow the leg. And it just left me with this sense that be careful, David, about any premature conclusions about what's possible. We don't know what's biology. We don't know what's belief. But as psychologists, we have to sort of straddle that fence. And I find that's especially true with patients with chronic pain who can get locked into what's real and what isn't. It's really there, or I'm being told it's in my head. And it just creates this maelstrom of complications in treating the case. So I'm just drawing on a very long ago experience that helped me appreciate how we tread lightly in this world of what's possible without, as you said, David, challenging a belief where they only double down twice as much in ways that are sometimes not helpful for them. You get where I'm coming from?
Sure.
Yeah. So just an observation, not necessarily something you have to respond to.
Well, one association, Candace Pert we'd have her at hypnosis meetings and she'd talk about how endorphins work and so on. One of her points is that endorphins are all over the body. They're not just in the brain. And so trying to see I think that's a really good example of it's not just restricted to the brain and there's a fluidity to all these things. And so there's a lot of different ways to look at it. But I think the main thing that I want to point out is that when we're working psychologically with patients that are very locked into an illness model, that very often, if there isn't some type of shift, and in a way, the way we like to put it is, look, you keep looking for surgeons and go see this guy and keep doing that. But in the meantime, would you like to find some ways so that you have less pain while you're looking for the solution? And I think if they hear, if I work with you, I'm going to have to stop taking my opioids, that's never been my approach. It's like we're doing this in tandem, and I think patients are a lot more accepting if we or so.
Well, it's like you're talking about how do you flexibly, creatively, and relationally work with a person's existing framework that will not make them feel threatened, right? So, it's not going to make them feel like, oh, you're going to take away my wheelchair if I want it. You're not going to take away my strong desire to cut off my damn foot, right? But like that's actually coming from somewhere, right? I think we've all had patients who just are repeatedly seeking surgeries. Like there's something in that they like about having, some kind of action done. And it speaks to one of the more profound things I've heard that you told me, David P., many years ago, which is when, someone comes to you and says, hey, can you fix my pain? You say, I don't know, but I can help you change your relationship with your pain. So what I want to ask you is, how do we as practitioners give patients something without taking something away that they're not ready to have taken away?
Mm-hmm. Well, and I think it's a great question, but that is kind of circling back to what my point is that, if they want to go up to the well on the mountain and put their leg in the well on a Sunday night because of these mystical things, I think one of the things we say is, look, you keep doing it. It seems to be helping a lot. In the meantime, would you be willing to look at your activity schedule with me? Okay. And as an example, I heard Francis Keefe talk. He's a great pain psychologist. And he said, if one of the best things you can do to ask a patient who's hurting, one of the best questions you can ask them is, what did you do yesterday? Because it's usually what happens the day before that makes us really hurt. And that's just one of so many examples we can use. But I'm saying, don't take the magic well away, but saying, in the meantime, would you be willing to try some other things? Now, then going to an MI model, you say, so what are the good things about holding on to your current approach, and what are the not so good things? So you don't say, you could keep butting your head against the wall forever, or you can start taking my advice, which we know is going to push the patient the other way, by the way. But rather than doing that, we'd say, well,
because you're butting in, so they would rather butt their head against the wall. Sorry, I couldn't resist that.
Right. That's right. So, let's talk about the advantages about how you're approaching things, and what are the things that are not so helpful, which is the kind of the essence of MI, is you're trying to get them to voice a positive change. So I don't know if that answered your question, Eric, but those are some thoughts I had. Yeah.
It totally does. And I think there's a structure in your language that I really want to call attention to. which is where you said, in the meantime,
Right.
would you be willing? Or said
Right.
another way, and would you be willing? Or yes, and would you be willing? So it works around the defenses.
Mm-hmm.
Eric has often said that for him, one of the pillars of hypnosis is attention. Okay. And I certainly feel, you said this earlier, Dave, that people are preoccupied or overly focused on pain, right? They're attending to their experience, their sensory experience. So the phrase, in the meantime, while this, then what about that? You're already inserting into time possible shifts, and you're redirecting attention. So even without formal hypnosis use, you're already employing some of the elements of hypnosis to begin to modify the sense that chronic pain by definition is now and forever, and that it's unrelenting, it's only this. And instead, in the meantime, you're saying, well, we don't know about how long it'll be here, but while that may be unfolding as it does, could you look and explore this in the meantime? I think that's a very powerful and even profound shift in perception and attentional deployment that I think has some real positive possibility.
Well, and let me take that, what you both said very, very eloquently, and Eric was kind of doing this with the hypnotic language, but this is some of the more recent work I'm doing on engaging what I would call what we scientifically know about the unconscious, how the unconscious works. And one of the things we know about the unconscious is the incubation effect, that if you give a human a problem to solve and we shift their attention and we shift our attentions as humans, our brain continues to work on that problem. And that's the incubation effect, which is well established in the literature. One of the things I like to do is to translate these into really practical applications of hypnosis. And so, Eric, you were doing this a few minutes ago, but and Dave, you were talking about the timing. So very often what I say is, I wonder when these internal resources are going to allow you to experience that shift. And I don't think it's going to necessarily be right now, or even an hour from now. It could be that 2 weeks from today that you're walking down the street and all of a sudden you notice a difference. I don't know. Maybe it will be this or then and so on. But I really not only like the idea of building unconscious resources, but giving this type of time sequence where it's unpredictable, because that's really what happens with change anyway. It's usually someone walks off or gets some type of notion for some type of perceptual shift or existential shift, even in the brain, but you don't know when it's going to show up. And I like reinforcing that concept with hypnosis.
And I got to follow that up with a question that's going to seem a little bit out of left field, but it's one, we actually talked about before the interview.
Mm-hmm.
You've been very candid in talking about your grieving process of losing one of your sons.
Mm-hmm.
And I was just struck there that in that example you gave, you're basically saying, I don't know what's going to happen in time, but one of these days you're going to find that blank. So if David Patterson, who's here right now in 2026, could go back in time to the version of you when you had just lost your son, what knowledge do you have now, having gone through something that, is so hard to bear, to kind of imagine before it happens? What would you offer your younger self in terms of what you learned going through this grieving process?
Yeah, good question. And I think I probably want to address. So I lost my 26-year-old son to a counterfeit overdose a little over 3 years ago, and he was at the top of his game, and didn't know he was ever using drugs or anything like that. But the thing that it was a crash course lesson in extreme grief. So I've lost both my parents and I lost both my siblings at early ages, and so I've certainly had my share of loss. But the thing that I can say about losing a child is the pain that comes with that is in another ball field, and I one of the one of the things that was very interesting is I could not hang out with people for a couple of years unless they had had a significant loss, or unless they had lost a child. It was everything that we would talk about would just seem too superficial for me, because so there's elements of the grief of losing a child that is ineffable. It's almost impossible to describe. And I see Anderson Cooper doing a lot of work on grief, and I think he does some nice things. And I've heard grief experts, and they have these models of grief. But very often, when I see these folks talking about that level of pain, I can tell that they haven't lost a child, and it's really difficult to explain the difference in quality. So I write about this a lot. I blog for Psychology Today, and I have pieces on what to say to your kids about using fentanyl, and then I've come to various concepts that one of the things that I've discovered with grief. First of all, when you lose a child, you realize that grief is never going to go away. On my deathbed, I'll be having a similar amount of pain, and there's this type of indescribable core of pain. And really, what us parents usually do is just grow around that pain. We develop our lives around the pain, but it's like there's a tumor there that will always be there. So that's kind of you start getting past the notion that this is going to go away, and my goal is not to feel this. I've been, my more current writing is I talk about some people with chronic pain don't want to let go of their pain for any number of reasons. But I've decided that I don't want to let go of that horrible. When I get to these episodes of indescribable pain, I don't want to let go of it, because it really, the yin or yang side, the other side of that is how much I love Billy. So,
And you're saying like the pain is a way of really kind of connecting to your love for Billy.
yeah, exactly. And but the emotion, and I don't know, if we even want to get into the difference between emotional pain and physical pain, and very often that there's an overlap, but sometimes there isn't. So I don't know. Those are just some of the comments I have about I would say severe complicated grief would be, anyone can feel it over any loss. I think children tend to bring it out the most, but you can't compare different types of grief anyway, because and we all are certainly going to go through it at some level.
Well, my main reactions are, first of all, thank you for your willingness to share it, right? To open up and talk about it. I think the second that I think is really profound is the uniqueness of our suffering, right? How do you compare this pain, this loss to that? They're experienced by individuals, and each one has their own way of relating to it. I think an important part that I heard is the importance of checking whether you're using a model of healing, curing, overcoming, or, as you said, Dave, when you're working with people with chronic pain, learning to manage, right? And then the last piece that I heard that I think is really, really important is the idea that my life sort of continued to grow around this core, but this core is not changing, right? The abscess or the tumor or whatever language you want to use. And I think I have found in my work, whether it's with chronic pain or even with trauma, where people in effect are reducing their life to just this. And what we're trying to do is to help them recognize there is life growth around this. So you're not reducible to only this. This is what this is. This will probably always be, but there are other parts of life that continue to grow and expand around that. So those were some of my reactions to what you so poignantly shared with us.
I'll share a few as well. When I was in high school, I guess it was the end of high school, I had someone who I was friendly with in my youth group. She was murdered in a horrific murder that got a lot of headlines at the time, because basically the majority of the family was slaughtered by a contractor that they had in the home. So it was her and her two sisters and her father, and her mother and brother happened to be out of the home at the time and were spared. And I went to that funeral, and just everything about that whole experience is kind of indelibly seared in my memory, from, her mother's wails to just the profound sense of grief and loss. And just actually about a year ago, I ran into her mother, and we didn't know who one another were. And I don't think her mother knew me back then, but I have seen who she was. And so I brought up her daughter, and we were talking, and her mother had healed around the core of that loss. She had remarried. Her son had married and had children. And I guess what I'm just trying to kind of succinctly say, first thing, I was so struck by how emotionally accessible she was. But I think the second thing was, like, she had both found happiness and fulfillment, but just the pain and the loss and the suffering remained with her to that day. And I was just so struck by how both of those things could exist simultaneously. So I just wanted to share that.
Yeah, and it brought up something for me, and thank you for that. That's a really good illustration. But one of the things that I wrote about after losing Billy is how to talk to a parent who's lost a child. And I point out that if I had one more person tell me that no parent should outlive their kid, there's a truth to it, but it's not helpful to tell a parent who's going through that. And what I kind of come to the conclusion is it's better not to say anything than to try to say the right thing. And I don't know if you're familiar with Nick Cave. He's a really good performer, a kind of a alternative rock guy, and he lost his son took LSD and jumped off a cliff or fell off a cliff. And Nick Cave talks very openly about it and just about what's helpful from people and what's not. And what he said is he lives in a small coastal English town, and he went in to get coffee. Just a really touching story. But the girl that gave him change didn't say anything, but she gave him the change, and she held his hand for much longer than. And so his point was it's much more what you do than what you say in these circumstances. And so it's one of these things about, even with any types of pain, not thinking you can know what's going on with the patient. And really, I think what a lot of your podcast about is being relational, but just really being attuned to the patient. And lots of times some type of physical gesture will be much more powerful than anything that you can say.
Well, that's why I thank you. And I guess for me, that's what I was trying to convey earlier when I was talking about the different interpretations of the word touch, right?
Mm-hmm. All right.
I think at our core, what you and I are trying to do, Eric, is to recognize that there's so much BS in the language that's being promulgated on social media, so much false misinformation and disinformation. So we don't necessarily trust the words. People are lonely. People are alienated. The APA said that in 2026, it's the highest rate of reported loneliness and isolation in many, many years, at the very same time that we're surrounded by connections, but they're false connections. So in that cafe, this young gal's hand holding yours wordlessly, even this amount of time later, brought tears to your eyes, because that was a real touch.
Yeah. Just to say, that was Nick Cave's.
Oh, thank you.
Very touching.
Funny, I heard it as yours.
Actually, I think the fact that you got that mixed up speaks perfectly to it, because
it's touching.
Think about all the layering happening here. Like, you are being so open with us and with our audience about your loss and your relationship with Billy and your pain, and then that prompts David and I to share kind of our own associations, experiences. And then you tell this story about Nick, who, you don't know, but you know his music, you know his story. And it feels like she's taking all of our hands, and feels like we're trying to just kind of hold this moment in the embrace of being here together in the pain. Thank you so much for sharing that.
It's probably a good note on which for us to wind down this beautiful conversation. Dave, anything else that you wanted to make sure our audience takes away from you?
Just, I did want to say that and this is an article, it's not just a book, but this model that Elena and I have written about, and Mark Jensen always pushes this, that there are at least 8 domains, like when you're working with chronic pain, that, if you're a psychologist working with someone with managing chronic pain, there's 8 domains, and one of them is we did a study with meditation and groups with VA, with veterans with chronic pain, and got really good results. But and one of the things about meditation is you're not trying to take the pain away. I think you're trying to change brain processing so people don't hold on to it as long. And so, but my whole point is that to do really effective psychological work with chronic pain, you want to spend at least an hour in a biopsychosocial assessment. And then there's all these routes that you can go and you can combine so some of them. And part of the work can be to, lessen the pain, but there's so many other things, increasing activity, getting back to work, all these distractions. And so, that's the side about managing chronic pain. I'm really recommending it be a psychotherapy in itself, and that psychotherapists can do it even if they're not experts in pain, if they just understand these components.
That's a good point. Yeah. So Dave, thank you. Thanks for coming on. Eric, as always, thanks for co-hosting with me. Our back and forth was really, I think, good at pulling out some wonderful things that are going to be of benefit to our audience. So thank you as well. So on that note, to our audience, we'll get this up and available to you shortly. Look for it. And on that note, I say thanks and take care.
Good. And I'll say it's a pleasure working with you, gentlemen. And I really actually like the way you work with each other and off each other. I think it's not a good cop, bad cop, but that would be a fun way. But you do have kind of a nice way of balancing things out. So it's a very fun experience for me. Yeah.
Thank you for being with us. Well, David Alter, probably one of the rare episodes where I'm going to be saying your full name to avoid confusion. That was really a wide-ranging yet deep conversation. I think the thing that stuck the most with me as a metaphor for the whole conversation was when David Patterson talked about how when he lost his son, there's just a hole there that is always going to be there. And life is about, kind of building around it while recognizing and acknowledging and being at peace with the fact that that is a hole that cannot be filled. What did you think about the interview? What stood out to you?
Well, a few things really stood out to me. First of all, David Patterson, Dr. Patterson, is a world-renowned expert in the management of chronic pain. So it's really, really helpful to learn from someone with that kind of caliber of experience and expertise. And it's especially helpful because it left me hopeful. It left me with some things I could grab that could be helpful. I think the second thing is he's amazingly accessible. Many of our guests have been very approachable, transparent, and vulnerable in sharing with us the challenges of doing the work that they do. And I would say the third thing that really stood out for me is people often get locked into this idea that if there is a problem, it has to be erased, right? That's the only way forward. If it's here today, it has to be gone tomorrow. Otherwise, it is not really effective. And I think especially with pain, Dave was excellent at helping us recognize it's not about eliminating, it's about transforming, a word you and I love. Mm-hmm. It's about modifying and managing. And the point is that life can be fantastic, even if we are not able to 100% eliminate a problem, because that's what life is. Life is never perfect, but it can be joyous. And that joyfulness doesn't depend on complete elimination of anything from the past that hurt.
It's about living with. And when that becomes your goal, maybe there is also change but change can't always be the goal. First you have to just get to living with, being with.
Yeah, and I would say even living with, being with is a powerful form of change, but it's not the form that most people think about when we see them in our office for the first visit. So I hope you enjoyed as much as we did. It was great to share this little bit over an hour with Dr. David Patterson. We hope you enjoy it as well.
See you next episode.
As always, thank you so much for tuning in. We look forward to catching up with you again in our next episode. A quick reminder, while we are both doctors of psychology, this podcast is not a substitute for professional medical advice, does not offer diagnoses, or engage you in actual treatment. The conversations, the opinions of our guests, and any information that we share here are meant for your general knowledge, your learning, your inspiration, and your motivation to put some of our ideas into practice in your day-to-day life. Remember that everybody's body and everybody's personal health journey is different, so what works for one person may not be right for the next or for you. If you have questions about your health, any psychological or medical condition, or any changes that you're thinking about making to your lifestyle, your diet, your exercise routine, your medications, or some other aspect of your life, it's always best to talk with a qualified healthcare professional who knows your personal history. Never ignore or delay professional advice because of something you heard here with us. We want you to enjoy the show and to walk away with useful insights, but ultimately, you are responsible for your own health decisions. Please use your best judgment, stay curious, and always listen to your body. Take care, be well,